Good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. It gives me great pleasure to present to you Professor Steve Jeffrey, the Professor of Obstetrics and Gynecology and Urogynecology, and I rate him as one of the very best, in fact, one of the top 10 urogynecologists in Cape Town. So he's accompanied by me. My name is Peter de Jong, and I'm going to be listening and moderating his talk this afternoon, which is an overview of vaginal laser therapy. Steve practices at the Christian Barnard Memorial Hospital, and he also practices at other institutions. But tonight we're presenting from the Christian Barnard Memorial Hospital, and I'd like to thank the Pelvic Floor Foundation of South Africa for sponsorship of this talk. Steve isn't a person that needs any introduction, and he certainly won't get one from me. So without any further waste of time, Steve, I'd like to thank you for presenting this afternoon. And we look forward to hearing what you're saying in this Women's Rights Month. The month is, in fact, Women's Health. And I'd like to celebrate that by presenting Professor Stephen T. Jeffrey on vaginal laser treatment and update. Stephen, what does T stand for? Thomas.
It's a very old family name, Pete. Cornish name from many years ago.
Theophilophilus.
Yeah, it's a very long
name.
Yeah.
Okay, Steve.
Good. Right.
Without further waste of time, vaginal laser treatment and update.
Yeah. So thanks very much to Pete for that very kind introduction. And so we're going to be talking a little bit about vaginal laser treatment, and it is quite common. It's become quite popular over the last 10 years or so, Pete. And I do have a disclaimer. I certainly don't think I speak from a complete position of objectivity, to be honest, because I have a laser machine in my office. I've been using it for almost 7 years now, and I've been treating patients for 7 years with laser. And I do have a little bit of a like for the results. So and my anecdotal experience with it is actually really good. So
although this is a disclaimer, you're actually speaking from a position of experience.
Yeah.
So
and
it's not really a disclaimer.
If you want to call it like that. Let's just see. Just move the slides. So there's a lot of media attention. This is from a little bit of quite about almost 9-10 years ago that this was on the Mail Online, and the patient said it's like going to the gym for your vagina, and she says this laser treatment actually saved her sex life. So it has got a lot of hype around it, a lot of media attention. You go to the aesthetics clinics, you can have it. So that's really what we have been seeing over the years and decades of that. But today I want to maybe see if we can bring it back into the more realm of standard medical therapy for patients, especially patients with vaginal atrophy. And I want to maybe open your minds a little bit about it. If you have maybe a little bit of a preconceived idea about it and not really maybe wanting to think too much about it for your patients. It has got a lot of good peer review from very well-renowned experts on these things.
Who are those two people?
Well, don't you know these people?
They look familiar, Steve.
Yeah,
Are they?
I mean, these are the Kardashians.
Kardashians. Now, which is which?
Kim is the one on the left, and I think her name is Chloe, the one on the right. Maybe someone else can help us with
it. Is that the one that was a man?
No, Pete. Sorry, Pete. I mean, I can't help you with this. You don't know anything about this.
They're before my time.
Okay, but just a few basics on these issues. So the two types of treatment modalities. Okay, we're gonna. I know a lot about laser. That's really my experience level. Talking about CO2 laser is the one type, and then you've got erbium YAG laser. And then the other treatment modalities, radio frequency, which I think is available in South Africa, but I think laser is a lot more common.
See, radio frequency is not technically a laser.
Not laser.
No.
But it's a thermal ablation technique that has similar results or done for the similar indications to laser.
Yeah, because many years ago, not many people remember, but radio frequency endometrial ablation, Steve, was something that we did, and it was technically called microwaving the uterus, and it was withdrawn, in fact, because these microwaves, these radio frequency waves caused all sorts of fistulas and damage to the adjacent bowels. So although radio frequency and endometrial ablation was hyped up many, many years ago, it was withdrawn because of collateral damage to the bowel. Do they still do radio frequency ablation?
No, I don't think so. I
Okay.
don't think there's a treatment.
All right.
I'm not sure. Yeah, we can find out. There are a lot of devices now available. You may recognize some of the names. There's FemiLift, which is a very popular one, FemTouch. Yeah, so I think those are the ones that are available in South Africa. But
Which one do you have?
in fact, my one isn't on this list. It's a Gynaelaze it's an Italian machine. But currently my machine is in Pretoria being repaired because after 7 years it's needing quite a big revamp.
Okay.
Yeah, I mean it is something that has become rather popular amongst a group of my patients, and some returning for their 7th, 8th, 9th, 10th treatment.
Steve, I look at some of these names and I say, it's a lot of marketing here, and without going too deeply into it, it does sound very sort of suggestive. Look at that one at the bottom. So there must be
Vaginal. Okay, but I mean the ones that are kind of popular that we Dika, that the Smart X side. There's also the Fitonas become quite a popular group. But as you can look, if you just look at the right, fractional CO2, and then you got the Erbiag.
So your one is the fractional CO2.
So it's CO2. So here's a Mona Lisa Touch, FemiLift. I know Natalia Novikova has been using the FemiLift for a long time. She's got a very busy practice up in Gardens here in Cape Town, and she's basically doing a lot of that as well. But I know that the advantage of that machine, after speaking to her, is that you've got this nice plastic cover that each patient then gets to keep, and they know that it's obviously been specially sterilized for them. Whereas other machines actually have a sterilizable they don't have the unspecific cover, you'll see. But the difference between the two is that CO2 causes a little bit more superficial burning, but the Erbiag has a more deeper thermal effect. That's the sort of theory behind the whole thing, although I must say I'm not very much an expert on the technicalities of the whole thing. But this is how it looks when the probe goes into the vagina.
And this is your one, Steve? This
is what my one does look like.
And that's the Erbiag or the CO2? That's the Erbiag.
They both have I think they both have a similar way of applying the laser.
Okay.
But the bottom line is that the laser is basically shot out of this probe down this thing, and there's a mirror on the end here, if you can see my cursor, and that shoots the sort of the fractionated laser. So this laser gets broken down from one beam into multiple beams that then does the fractionated laser treatment. There's a little video. You can actually see how it actually gets done. This is a little spacer that then just gives you an idea as to how deep you are. And you can actually see the laser gets shot down. These little markings are 1 centimeter on the probe. And then you're able to check exactly. And that way you basically try and cover the whole vagina with these fractionated laser beams.
Is it uncomfortable to have that inserted?
It is not the insertion, but look at it, there is a thermal effect. So especially if the patients have a lot of atrophy, older patients, they do feel it. So we do give every patient some Emla cream that they try and apply an hour before. That's a local anesthetic cream, Prilocaine. And if they have enough of that, it does seem to become relatively tolerable. Sometimes people give them either some Brufen or even a little bit of Targinact. But most patients actually tolerate it quite well, and no downtime or like that.
Just go back, Steve. Did you say the next one? Collagen, is it collagen regeneration? Is that the?
Well, that is one of the things it does. It lays down some extra collagen. We can just another picture, a little video of it. You can actually see. So you can actually see the patients. So in terms of things we do to patients, this is really quite minimally invasive. So there we go. This is one of the other machines. Just really the principle is fractionated laser compared to the tissue ablation laser that you might do for a normal pap smear. So that's fractionated, the beam gets broken down into multiple beams, and it leads to collagen formation, improved microvasculature, and enhanced tissue oxygenation. And yeah, again, one last, you can see this laser beam gets broken into multiple beams, and it's these small beams that then create this tissue stimulation that lays down this extra layer of tissue. We do an internal, and then we also do an external, and this is, we then do the external through this other one, and there you can actually see what happens to that beam. Activate the machine. You see this fractionated beam ready to causing that new test. Okay, so we basically do 3 treatments, 6 weeks apart. And yeah, as I say, it takes about not more than about 10 to 15 minutes.
10 to 15 per session.
Per session, yeah. Well, this is just this is when I was doing a theatre. The patient there, and I think we're doing something else, and I offered her a laser. And this is what you might see on a colposcopic view, slightly magnified, and you can actually see these multiple little dots. But really, the magic happens in between these dots where the tissue activation happens, and you get that laid on of new tissue. Before and after picture, you can actually see a nice thickened vaginal epithelium after you've done the laser. So this is one of the first articles on this that was done by a group in Italy. Stefano Salvatore was one of the pioneers of this technique, and you can see how the tissue from the picture, the histological picture on the left to the right, you can see a nice thickening of the dermal layer, leading to improved function of the vaginal epithelium because of that extra thickness and better tissue, including vasculature and collagen formation. So the main indications for laser treatment are atrophy, and I think that is one of the best uses of the laser. And then it has obviously been used extensively for vaginal tightening, which I think it does work for. There are multiple reports and anecdotal and some scientific evidence of an improvement in sexual function. And in fact, my previous partner who actually was instrumental in buying the machine for this practice, Peter Kruger, did a patient and she had an orgasm for the first time in her life after he had done a laser on her. So there are some significant improvements in sexual function after this in many patients. I've started to look at it for patients with stress incontinence, and I'll show you some data on that, and also overactive bladder. And then I've used it occasionally in patients with lichen sclerosis as well. This is not without some controversy, and there has been some sort of noise around this, and with some people dismissing the treatment quite extensively. And this is even from one of the JAMA Open Network's commentaries, where this Jen Gunther actually says, how many quality studies showing that vaginal laser is ineffective for GSM must be published to halt its use outside of appropriate clinical trials. And really just dismissing it extensively in terms of its treatment, and questioning the ethics around the use of this, because it basically, she's saying that there was no evidence that it actually worked, which is completely incorrect. I can show you some facts to show that it actually does work, and the evidence definitely supports the use of it. So I very comfortably go ahead and continue to treat my patients with laser. This is just one other study, again from Stefano Salvatore. Normal premenopausal patients, vaginal epithelium, histological picture on the right here, nice and thick tissue. And this is a pre and post laser treatment in a postmenopausal patient. So you can see it actually moves the patient into a realm of where they do certainly have a much better vaginal epithelium. And this has been my experience in these patients from an anecdotal point of view as well. So let's look at, I'm gonna blast you now with some data, because just to show you that there is a lot of evidence now. You can see the first study being published by Stefano Salvatore 10 years ago, 12-week follow-up with VHIS scores, which is the standard vaginal health index score. And in 50 patients, there were significant improvements. So this is one of the first studies there by Eleni Pozzini, again, Greek and Italians looking a lot at this stuff. But in this specific study, you can see very significant improvements in a full range of genital syndrome and menopause symptoms, ranging from dyspareunia, dryness, itching, dysuria. And then also on the female sexual function index questionnaire, which is a very standard and one of the best questionnaires for sexual functioning in these patients. And there you can actually see significant improvements in the full range of symptoms that you get related to GSM as well.
Steve, are any of these trials, I'm sure you're going to show us one or two, randomized to include?
We're going to run through that. So
Okay.
I'm showing you some of the older data to
Right.
start off with, and we're going to run all the way through to the comparative studies, RCT, and then there's some systematic reviews as well. So we can just look at a different quality of studies. But these are the very early studies. So obviously this data didn't. Are you going up?
No, I'm just
Okay,
taking a
okay.
photograph of the question.
Okay, good.
For
All right.
CPD.
Okay, fine. So I thought I'd said something. But anyway, so basically, poorer quality studies in the beginning, another very small study, but again, showing some very promising results. And yeah, you can actually see some of the bar charts. I don't know what you call this type of study, box and whiskers chart. But
Box and whiskers.
yeah, it's the box and whiskers chart. Never heard of that before.
I've never heard of box and whiskers.
No, it's a special statistical chart. Box and whiskers. That must be the box and that must be the whiskers. But let's not detract. You can actually see in the specific VAS scores in this patient's very good improvements, dryness, burning, itching, and dyspareunia. So, okay, let's look at some of the comparative studies. This was one of the very first studies by another Italian group comparing laser to estriol. Estriol is basically silent-pause, and very good comparative improvements. But in fact, in this study, the laser appeared to be statistically better in this. They were looking at the vaginal health index score. So this is lubrication, pain, dyspareunia, those different parameters on that score. And then going into some of the more specific VAS in this study, vaginal dryness, dyspareunia, very nice improvements in both estriol, vaginal estrogen cream, and laser. Obviously, these patients either had laser or estriol. It was a comparative study. And in fact, the improvements in the laser group were sustained up to a year and even 2 years after the treatment, which was better than in the patients who had the estriol.
Yeah.
But
how many
not
patients were
RCT,
there?
very small.
Oh,
I think
small.
yeah, small studies. These are all very small studies. This is by Adrian Gaspar, Argentina. Again, gag laser, but again, good improvements in both estriol and the laser treatments in all parameters. So this was just really encouraging me to look a little bit further. This was the first RCT by Cruz et al. And the other actually had 3 groups: laser, estriol, and then they had a group of laser and estriol. So I will very comfortably treat a patient with both vaginal estrogen cream and laser at the same time. Often they've tried the estriol and it's not really giving them enough relief or quick enough relief. And I think you can actually boost the treatment by adding a laser therapy as well without any problems. In this group, in fact, the laser and the estriol was obviously the best, performed the best. But the laser did perform a little bit better in some of the parameters than the estriol alone. But there was a slightly increased number or worsening in the pain scores in the laser group. So we do need to just bear that in mind. There are a group of patients who might have had a little bit of pain after the laser treatment, but it's not very long. It only lasts for 1 or 2 days.
Are there any long-term side effects?
Okay, so that's obviously one of the big criticisms. People actually even might suggest a previous very bad controversy of the vaginal mesh. So obviously people are very scared of new treatments that aren't very well researched, very extensively studied. And so that was maybe why people said you need to be really careful with the laser treatment. But there's been nothing in my reading, in my research, and in what I've looked in the data that has made me nervous about doing this in any long-term effects. Remember, most skin therapy clinics that you go to in Cape Town around the world will have at least a number of laser type machines in in their offering. So if you go to Skin Renewal, actually, which I can see you go quite regularly.
Steve, I need to go. I'm sorry.
You will you will see that they have big and a small and a half-size laser machines, and they're doing all sorts of therapies that you know, don't even, some of them include laser, some include all sorts of other things. But in the end of the day, they've been doing this for a very long time. And yeah, so just looking at this systematic review now of about 2,500 patients, where they included randomized studies, some prospective studies, and some retrospective studies. There was no difference in this specific analysis of all these trials, where there was no difference between vaginal laser and topical hormone treatments, and there was no difference in patient sexual function scores. And they really made a conclusion from this specific systematic review, where they found that this non-randomized data supported energy-based treatments in improving vaginal symptoms, sexual function, and clinician-reported outcomes. When you're out, you're just looking at this systematic review of about 2,500 patients, which included 3 RCTs, 16 prospective studies, and 7 retrospective studies, where it actually really supported the treatment of patients with postmenopausal symptoms.
And I just see, when was that published, Steve? 3 years ago.
Yeah, 2021. Okay, so this is a systematic review meta-analysis. This is another one, a systematic review meta-analysis. Is also published around 2-3 years ago. I'm sorry, I don't have the data. But again, all the studies showed significant improvements in this atrophy type symptoms. And here you can actually see those forest plots from the different studies, going all the way down to dyspareunia, dryness, itching, and dysuria.
Were those statistically significant results?
They were. The way the forest plot works is that if these lines don't cross the central line, then it is significant. And you can actually see
only one does.
And this, so this block here, this thick sort of black block, represents the sort of the summary of all those studies. So if you count this one, 1, 2, 3, 4, 5, 6, 7, 8 studies looking at dryness, all found significant improvements with an overall summary of a good improvement. Okay.
Steve, I'm just running my eye down the left-hand side. I hate to say it, and can I play the devil's advocate? But your friend Salvatore seems to have done all the studies. If you look over there, 1, 2, 3, 4, 5 studies, here's the second one against 4. Does his data not skew the outcomes, because most of his data is your friend Salvatore?
Absolutely, Pete. These are all small studies, and you know, this treatment therapy is still new. It's been only on the market for about 10 years.
All right.
So absolutely, and you will have your protagonists. I mean, we've already looked at a lot of these studies. We looked at the Pizzoni study. We've looked at a number of the Salvatore studies, but there are some newer trials here, and we can look a little bit later. We're gonna get to that in a minute.
Why is it that they're almost all of them? Mauro Cervigni is a well-known Italian, and all the other guys.
Nice guy.
Very nice. Very nice man. You know, why are they, most of them, Italians? This is not widely available in the rest of the world.
No, well, I mean, they are doing it in the US a lot, extensively. You know, I'm not giving you the full summary of all the data here, possibly. And if you go to a conference, I mean, there's certainly some RCTs. Christian Phillips, who you know, from Basingstoke in the UK, very, very big user of laser. If you go to IUGA, he'll definitely be on the program speaking about laser. And he's one of the guys doing RCT, laser and stressing conference. So they've got a multi-center study going with Anna Rosamilia from Melbourne, who you know very well. So there's some really well-known people who are looking at this and using lasers. So it's not something that I think you can dismiss completely.
So this is in the mainstream, and
I think so. You know, I think it's no, these are all in good journals. I think maybe the bigger worry maybe is maybe what you might find in terms of what is published regarding some of the adverse events. And here you can actually see the main thing is a little bit of pain, discomfort, a little bit of bleeding afterwards. But you can actually see there's no one who's got cancer. There hasn't been any major like bowel or bladder injuries or
no fistula,
no spectacular disastrous outcomes from any of this that you can see.
Yeah.
But we'll look at that in a few minutes. There are some more data on this. There has been some data now looking at sham, because I mean that RCT versus a proper placebo would probably be the best. This is from that guy.
They look like Sri Lankans.
And probably Americans, Sri Lankans working in America. You know? I don't know exactly where they're from.
That's a Sri Lankan.
But this is in a good journal, the Menopause Journal.
Yeah.
And here you can actually see that they said that that the application of microablative laser therapy in terms of CO2 laser was effective in treating genital atrophy. And this was 88 women, a sham-controlled laser treatment.
And it's a 2020.
Yeah,
it's a very recent.
so that was recent. There you can actually see where they'd used some really good outcomes, VHIs again, visual analog scores, and ICIQ. So these are good. There's good parameters, and you can actually see these things are statistically significant. So
Yeah.
more data to show that it is good. And basically the patients are treated.
So this was blinded. They didn't know if they were getting the laser or the sham.
They were doing sham, yeah. So they, I mean, I suppose creating a sham is, a challenge. What do you do? Do you put it in and then sort of activate it? So, I mean, we thought of doing some studies ourselves, but obviously trying to choose what to use as a sham is important. And then the question is, does your sham do something to stimulate growth of new tissue? I mean, you put your probe in, maybe it does create something of effect. So, what are you actually, how good is your placebo? So that's the other question. So this is just in terms of patient outcomes, patients were actually very satisfied in this group. And this is encouraging as well, that there was no difference in adverse events. So you can actually see no one had more problems in the one group versus the other when it comes to complications.
So there were no complications.
No. So I don't think this treatment is dangerous in any shape or form.
Yeah, I guess, Steve,
and that's the most important thing.
When you look at the mesh, I don't use the word debacle, I use the word controversy. There were really profound negative outcomes. Now, whether that was the mesh or the actual operators doing the mesh is subject to court cases and proceedings. So that's sub judice. But this over here certainly doesn't tend to be dangerous in any way, shape, or form.
I'm very comfortable doing it. As I say, I've been using it for 7 years now in my practice, and I haven't seen anyone who I've been overwhelmingly concerned about or vaguely concerned about any potential complaint or litigation related to it.
Yeah.
Okay.
I see that the sham, if you look at the middle one there, the sham says 44% of women were very satisfied or satisfied with the sham. So that is in fact the placebo effect.
Yeah.
Whatever you do, any placebo is going to have some positive effect. And the
double the number were happy in the laser group.
Yeah.
So there is something there.
Yeah.
And in the very minimum, you need to look and see what's going on there.
Okay.
So, I mean, the group of patients where I find this to be very useful are the cancer survivors, breast cancer survivors. They are reluctant to use estrogens, depending on obviously, your opinion about, which patients that have had previous breast cancer would still be inappropriate for estrogen. But this is actually safe in that group of patients, and it is certainly a good option.
Just go back to which is which?
Well, I mean, this is just a little paper again from these more Italians, I think it is. Very early pre.
And what is the left and what is the right?
Well, this is the patient pre and post laser treatment.
Okay.
Okay.
All right.
So my screen's a bit.
I see your screen's a bit buggered.
Yeah, it's okay. I can see. I don't see it anymore.
When I'm trying to look at the laser, I thought, is that your screen or is that the laser that's making that? Anyway, let's carry on. Steve.
All right, but so this is, again, just coming back to that very critical paper by this Jen Günther. I just wanted to show you that these are the papers that she quotes to support her very negative opinion of laser. So just not really including enough papers to support her quite negative opinion about it. And I think if you look at the general data available, it certainly does support the use of laser.
Steve, I see this US Food and Drug, the FDA, are they licensing this modality, or what do they say about it?
Okay, let's get on to sort of opinion and
Okay, all right, let's carry on.
group opinion about it and you know, regulatory you know, approach to this whole thing. But we're just going to quickly look at some of the other indications, then I'll talk about that, the important question.
FDA, right?
So you can treat also vaginal laxity, atrophy. It's this vajuvenation that they're talking about. In the more cosmetic type clinics or the cosmetic use of it or the functional approach. And this is from another study where they specifically looked at what they called vaginal rejuvenation, but it did actually, in fact, include quite a lot of the things that would have been looked at in many of the other studies. But yeah, they included a large number of women, 3,609 women. And they found that their results from this analysis would support improvement in these symptoms in these patients. And then then we get now to another group of patients. We're talking more now about the urogyne, classic urogyne pelvic floor dysfunction patients, your incontinence patients, and your group of pelvic organ prolapse. So this was from Katrina Markova. You'll recognize this is a very good and a very well recognized research group. Jan de Prest is
very well respected.
Very well respected, very ethical person, and so this analysis by one of his fellows, Katrina Markova, was really quite useful for me. You know, in terms of the fact that I hadn't actually really been using it for a lot of my patients with incontinence prolapse before, but I was very encouraged by the data from this analysis of about 31 studies, 1,500 patients. And there you can actually see, so firstly, I think reading these systematic reviews does get a little bit confusing, but so it helps you just jump directly to their conclusion. And here you can actually see that all studies on vaginal and or urethral laser application for pelvic organ prolapse and urinary incontinence report improvement. But the quality of the studies needs to be improved. So
it's unusual that all studies are positive.
They were, it was a very, if you go and read this paper, it was published in the BJOG. So it's obviously a good journal. So let's just look at a few of these. So there we go. Stress incontinence was the best study. Just going quickly to one of the sort of comments about stress incontinence. They say they identified the first and only randomized controlled trial in women with SUI. And together, one controlled cohort study, these studies demonstrate the benefits of laser. So I think it is something to look at for stress incontinence.
Steve, just two things here on stress incontinence.
Yeah.
What did you say is randomized? Was it randomized to a TVT type mesh?
I'm going to show you. I'll look at that in a little bit data. And there was some data from this analysis that also showed it to be improved in OAB patients. Okay. I do have, let's look at some of these, and not many studies in prolapse. So I think for stress incontinence, it might be a better option going across to OAB, also shows improvements, and in prolapse, maybe not as much. So this is one of the studies from a very nice lady from Slovenia, Dr. Blaganje. I think you'll recognize her. You would have seen her at Yuga. She's a very well-known.
Steve, I hate to say it, but sadly, I haven't recognized her.
Okay, well, I'll point out
Slovenia.
Anyway, but she looked at only one laser session for patients with stress incontinence, and in this case, using the YAG. But she found, firstly, very significant improvements in the ICIQ scores, with a fifth of the patients being dry in the laser group, with only 4% in the sham group. So it was statistically significant, but I mean, that's not really maybe anything to write home about if only 21% are going to be dry. But for a treatment which isn't really very invasive,
well, you see, that's the point.
Lunchtime,
that's the
not
point.
Not too bad.
You have to compare this to a modality like, for example, the TVT, which unfortunately has been withdrawn because of its mesh in many areas. So if you don't do a TVT with mesh, what are you going to do?
Yeah. So this is another study from this guy.
Uki.
Yeah. And he actually compared it, I don't know if it was he or she, but they took 3 sessions of laser. So this time it was more, which is the standard treatment actually. And they found that the laser gave 50% of the patients were dry, whereas about nearly 70% of the patients had a sling. and there wasn't a statistical difference between the surgery and the laser.
Whatever.
So it was an RCT. So definitely something in it. I am a surgeon, so I tend to offer my patients surgery and not laser. So I can't give you a lot of anecdotal evidence for the use of laser in these patients.
Well, Steve,
So-
you have to, if you're going to give them both options, they must decide. Are they
Yeah.
going to go for something at 50% with no side effects, or 70% that has very few admittedly side effects? The patient must make that call.
Yeah. So yeah, I mean, I do mention it to my patients, but you know, by the time they get to me, they you know, and you've seen them leak while you've been examining them, they often do tend to go for surgery. Look, I mean, the thing is, it's an out-of-pocket expense as well. But I think it is something you maybe need to mention to your patients, especially those who don't want an operation. And then for OAB, overactive bladder, actually very significant improvements for in this study again by Dr. Okoye compared to betmeger or fisoteridine, which fisoteridine is, I think, anticholinergic, 3 sessions of laser, and there was a significant improvement in the group. So maybe something to think about going forward. Some improvements in patients with prolapse, although I must say, I don't really believe it's going to really make the difference in a really big symptomatic prolapse.
You see,
Yeah.
just go back, Steve.
Yeah.
Grade 0 or grade 1 prolapse.
Yeah.
I mean,
Yeah.
I don't know what you treat, but I mean, that
Yeah.
sounds like
Yeah.
would you treat grade 0 prolapse? It doesn't sound like very much prolapse. A and B, why would it need to be treated?
Yeah. No, I don't really think
Okay.
even comes down to physiotherapy for prolapse, it doesn't really seem to make a big difference in the really big prolapse. So but yeah, then when it comes to sexual function in same analysis, you can see the quite a few studies looked at sexual function as well using quite good questionnaires, the FSFI and the PISQ. PISQ is specifically an incontinence and sexual function questionnaire, looking specifically at the role of incontinence and prolapse on sexual function. But again, good improvements in probably more studies than where they didn't show an improvement. So I think it is certainly something to think about in these group of patients.
And Steve, in your quite extensive experience, do you think it makes an improvement
Absolutely, Pete. I've got no hesitation offering patients this the laser
for
treatment.
sexual function?
Yeah, absolutely.
Yeah.
Especially, I mean, you know, I think especially if you see the patient who's got a lot of atrophy, they really do like it.
Okay.
And their partners are very happy that they've been for it as well. So you are making a difference at quite an important level to patients' quality of life. And they did take quite some time to look at some of the adverse events in this specific systematic review. And again, looking at the numbers of adverse events, specifically going to look at this column here, number of adverse events, and not reported in some of them, but relatively low numbers of a little bit of bleeding and dyspareunia, UTI, and again, this recurrence of genital herpes. Maybe it's the same patient for all the studies, eh? And coming down here to just look at the general, a little bit of discomfort, bleeding. So not a lot, and I'm very comfortable that there isn't anything lurking there for me in these patients that will bite us later in 10 or 20 years time. Lichen, not a lot of data, are some very small, maybe case report type studies, but it is worth trying in the patients who maybe tried your therapy of creams and you know, maybe some other treatments. So I was getting the odd referral for lichen sclerosis, and not bad improvements, but I don't think it's really the major bullet for the specific treatment. But it's worth trying if you ask for stuff.
I can't see why it would not work on lichen sclerosis. If
Yeah.
it works on, there's your pictures in
Yeah.
lichen sclerosis.
Yeah.
If it works on atrophy and it improves collagen and also improves vascularity
Yeah.
and all the other things you have mentioned, why would it not work in lichen sclerosis?
So if I have any questions, I think I'm just looking at the chat. There's no questions yet.
Okay.
So that's good. All right. We did do an animal study on this. There you can actually see my fellow researcher, Lenise Ross. And you can actually see this was done in conjunction with Katrina Markova and Jan de Prest. So he was part of the study. It was a sheep-based study where we looked at the role of CO2 laser on microcirculatory parameters in the sheep. But this specific study didn't show that the laser was particularly better than estriol. So we actually gave these sheep an estriol ring to walk around with. And so some had that and others had the laser.
And there was no difference.
Well, it wasn't really, you can actually see the laser is the blue one, and it's actually didn't really seem to make as big difference as the estrogen in the sheep. So maybe it's not the treatment for sheep.
But hang on, Steve.
Yeah.
Hang on, Steve. Were these menopausal sheep oofferectomized or not? Because
We
that
did,
would-
we actually, so at the same time, we developed an atrophy model for sheep as well. So we oophorectomized 3/4 of them. And we also had a group that weren't postmenopausal. So you can actually see the different groups. And so there was a, so yeah, there were postmenopausal.
Which is your menopausal sheep? Which color?
The blue one, the green one.
You know.
Yeah. But in the premenopausal control, was the yellow.
So even in menopausal sheep, it didn't seem
It
to
didn't really seem to, we were a little bit disappointed, but in the end of the day, what parameter are you going to be using to define whether therapy is actually going to be useful and transposable into a human woman? So,
Why do you think that in menopausal sheep, oophorectomized sheep, there wasn't a difference? How could you explain that? Because they must have thought about that.
Yeah, I don't think it, I think maybe we're looking at, well, they were looking at microcirculation specifically, and maybe that isn't the best
Parameter.
marker for it. Yeah.
I mean, there might be a better surrogate.
Yeah, and and I think what's really making the difference here is maybe the increased collagenase, and what may be happening at a micro neurological level. I think in atrophy, especially patients who are looked at with estrogen, there's some sensitivity issues there, and you can actually see even from an immunochemical level, we're seeing changes in patients mutate for estrogens. So I think that might be really what might be happening there. So we don't really know what's in.
Maybe you were just looking in the wrong place. Had you maybe done the collagen, or had you done the thickness of the vaginal skin, or had you done some other parameters, you may have found different outcomes. So that was the only one was vascularization. Okay.
So anyway, a lot of work for
no result, and a disappointing result.
Yeah. Okay, so the FDA, so a lot of questions around the FDA, and there was a bit of a news release, a warning, but things have sort of settled down a little bit, and firstly in this menopause journal, they really do come out and support the use of laser treatment again. And you can actually see these are all the Americans. There's Jennifer Anger, who's quite a well-known person. And really just looking at the number of adverse events, these things are all basically below 10%. And the key points from this specific article say that evidence to justify the FDA administration warning, which did scare a lot of people.
Well, Steve, you must remember that this comes on the back of the mesh debacle or the mesh controversy. And the FDA, I think, were particularly sensitive to criticism of their FDA findings on the mesh, and they were probably overcompensating or something.
Yeah. We've got one of our first questions from Siva Moodley. Do medical insurance funders cover litigation related to vaginal laser if it arises in South Africa? Well, answering that from first principle, Siva, I believe they would. I think you would really just need to follow the same principles that you do with any treatment. Do you can go for TVT or go and do a hysterectomy, you need to get consent from the patient, explain to them what it is, discuss benefits and risks, document it appropriately, and I'm pretty sure it will. Yeah. So,
well, Steve,
what do you think? What are your opinions on that?
My opinion is this, that you've persuaded us that it's highly unlikely that vaginal laser is going to cause any untoward effects. So whether this arises or not is the first question. If it does arise, there does seem to be evidence that it is safe. And having seen the evidence, for example, randomized controlled trials and collective reports, I would suggest that on the face of it, it does seem to be safe. So if some untoward effect does arise, I'd say it's unfortunate.
Yeah.
There's also an anonymous question. What does the anonymous say?
Good thing I remembered it. Basically, it was about do their funders
The
covered
answer is no.
cosmetic surgery. So, well, yeah,
Well, it's hardly cosmetic, but the answer is they
so
don't.
this wouldn't
cover it.
really fall under cosmetic questions and cosmetic surgery.
But the funders don't
Yeah.
cover this
Yeah,
because
yeah,
little
they
as
don't, yeah.
they cover as little as possible.
All right. So, but again, this was really written in response to this, issue that was brought up by the FDA, where they had a bit of a warning about it. Okay.
So hang on, what did they say? Steve?
Well, there was a specific warning from the FDA. I don't have the wording anymore, but the FDA was basically giving a bit of a warning in 2018. But there has been
Can
a
you just go
review.
back?
Yeah.
That suggests, it says here, from deceptive health claims and significant risks related to devices. I'd love to know to what they refer in significant risks. What are
It
these
was
significant risks?
well,
So
it
the
was
only side effect here is poverty because they're not cheap.
well, yeah. I do struggle a little bit with the very
Significant
negative publicity, and even amongst quite a lot of people in South Africa who just maybe don't support this treatment. And remember, a lot of maybe KOLs or key opinion leaders on vaginal menopause treatment using estrogens are potentially also maybe a little bit non-objective due to maybe relationships with industry, etc., pharmaceutical industry, because this does very much compete with your other menopause pharmacological treatment. So maybe I'm not saying that's the case in South Africa, maybe someone else in another country or would potentially be very negative about maybe because of the other alternatives which may seem to be better.
Yeah. So this is what interests me as a person that's got no vested interest in either camp. What are these significant risks related to?
I think it was anecdotal issues with
Okay.
pain or, yeah. But I can get you that, but that was almost 6 years ago.
Wow.
But yeah, so the American Urogynecology Association, which you might recognize some names here, Miles Murphy,
Recognize
Eric
Murphy?
Sokol, Abba Shabari, you must know Shira Glacier.
Yeah.
Okay, so a lot of people,
Miles Murphy is the
yeah,
chap that we
Bobby
know.
Garcia is he's basically got this whole put up this whole for Hugo's got a whole sort of position statement, etc. as well. But basically, it does say, yeah, for patients experiencing vaginal atrophy and dyspareunia associated with medical menopause, it was agreed that the energy-based devices have demonstrated short-term efficacy, and the benefits associated with fractional laser treatment for menopause last up to 1 year, and it might improve the DVA for more than a year. So, yeah,
That's vulvovaginal atrophy.
yeah.
Oh, what is fractional laser? Is that a misprint?
Fractional, yeah.
It's just badly spelling it. Yeah.
They do say here that serious adverse are infrequent, and they do have a favorable safety profile. So, this is again another group. It's the American Urogynecology Society. They're not just going to put out position statements when they don't actually believe. Okay, we do have another few questions here. Can vaginal laser therapy be used in patients who already have vaginal mesh or midurethral slings? Absolutely, yes. I have done that, and it doesn't go deep enough to affect the mesh at all. It's quite a superficial treatment. What is the cost to the patient per treatment? It all depends where you go, but I've been charging about 3,000 Rand per treatment. And remember, these machines go for about R1 million. So
wow,
to cover the costs, yeah.
Aren't they getting cheaper if they're made in China?
I haven't looked at the cost of a
recent
Chinese one, but yeah, they are going for about R1 million. You can between 900, 1,000, $1 million. I've actually got a costing on a replacement of my own.
And what sort of replacement cost? R1 million?
Yeah, 800. I think it's 898,000 or something.
So they're not cheap.
Almarie, thanks for a very sharing overview. Any data on duration of effect on SUI overactive bladder symptoms? Almarie, thanks for the question. Not really sure on that, but with all this, with every laser treatment, there's a drop-off in effect after about, I have to say, about 6 months to 9 months.
So you repeat it after 9 months?
I have been telling patients come back after about 6 to 9 months, because you get a dropping off effect in all the patients. I mean, it's, you're not removing the cause of the symptom, you're just treating the symptom.
It's a bit like Botox.
Yeah.
It eventually wears off. Bladder Botox.
Yeah. All right. We're nearly done. Let's just get the next slide. Okay, and the cost again. I mean, in America, they're gonna. I don't know what the conversion rate is now, but I mean, you're talking about 50,000 there.
What?
No, wwhat is that? Where is 22,000?
$2,000.
That's 50,000.
That is 50,000. Oh, Steve, you far too cheap, you know?
Yeah, let's push up my prices a bit. But anyway, look, I mean, in the end of the day, you're getting a lot of patients who old, they've got atrophy. It's more of it's less of a cosmetic treatment rather than therapeutic treatment. So I mean,
Can I just go back? Why would you do laser for cosmesis? Is it
what it
actually?
does, it does promote the improvement in the symptoms, you know, and yeah.
No, but cosmesis means visual improvement. So I don't understand how they can call it a cosmetic therapy because
yeah,
you see what I'm saying? If you improve a person's vaginal atrophy,
yeah,
how on earth does that
it's functional. Yeah,
it's more functional.
Yeah, it's a therapeutic. It's a good therapeutic option.
It's not at all cosmetic.
Yeah. Okay. Sorry, let's skip the next slide. So yeah, how much does it cost there? This was an interesting study that actually then looked at the whether it was whether the patients actually felt that the cost was justified. This is an American study, and the vast majority of these patients reported being satisfied with the treatment results and with the cost of the treatment. So you know, for what they were getting, they felt that it was worth the cost.
Majority.
368 patients were contacted, 122 were interviewed, and they really improved their sex life from once a month to a few times a month, and they felt that was worth the cost. So,
and those are big names. I mean, Mickey Karam, everybody knows who he is.
Yeah. So yeah, good guys, you know, high Cleveland Clinic, big Euro.
Cincinnati.
Yeah. So yeah, I don't think we've got time to read that one.
What is the bottom line on that? What is that about?
Well, it's just really supporting the cost, etc.
Okay. Yeah. So it's just cost effective.
Yeah. But again, no trials and cost effectiveness. You know, how much long-term safety do you need before you actually say, well, this is okay?
5 years? How does that sound?
Yeah, I don't know. I mean,
most people would say 5 years. If you've got a new thing, and you've been doing this for 7 years.
Yeah.
So you would have noticed had something
untoward
effect.
I've had a lot of I wouldn't say a lot, but I've had complaints about many other things we do in medicine. You know, I mean, you know, there's so many things we do to patients. We do operations, we do things, but of all the interventions we have, this is for me one of the safer things that you might end up doing to a patient.
If I
go and do a DNC on a patient, I mean, that's probably more risky than this. In my opinion.
What, in your experience of 7 years, what untoward effects have you had? You can be candid.
I think I would advise people to be very careful in the older patient who's got a risk of, who's got a lot of atrophy. Someone maybe in their late 70s, 80s.
What will happen to them?
It can be very uncomfortable. Yeah. So to really get the patient on board. Yeah, I think maybe one patient's daughter did call me 2 or 3 days later, asking me what I was up to, and you know, they had so much pain the next day. So yeah, I mean that was an issue. And remember, you're charging patients a fair amount of money for this, so you know, there might be some strange perception that this is something you do for the cash. Maybe the presenting symptoms might not correlate very easily with what you're doing. So, I mean, that specific patient needed, they were very atrophic, recurrent UTIs. How you going to do a laser on them? You know, there might be some questions around why you're doing the treatment. So, yeah, that's where it all comes down to how you consent the patients and discuss the treatment with them.
Maybe some OptiLube, which is a lubricant plus a local anesthetic. Very, very good stuff. Maybe a shot daily for the next 2 weeks might be.
Yeah, you end up doing. Yeah, you can tell them to take that.
Yeah.
But then again, you know, it's been used in face, neck, shoulders since the 80s. There's good histological data, and you know, the data I've shown you today actually does support it in my opinion. But breast cancer patients, I think they should all be referred for this if they're not going to go for vaginal estrogen creams. Remember, they often are. A lot of them are on estrogen receptor. What do you call those things? antagonists or whatever you want to call them, and they do often tend to have even more atrophy than the normal patients. And women in whom it's stringently effective, that actually works very well. But it's a safe, I think it's feasible to safe and it is effective treatment. So that's it, Pete. There's a question here.
Erwin, I'll just say, Erwin Gertner says, are you also able to use your laser to treat vulvovaginal warts and CI in 8 weeks? The answer is no.
Yeah, no, Erwin, thanks for that question. You have to use just your normal ablative laser. I think you and Joe are experts.
A
in
YAG
that.
laser.
Yeah, that's just a very specific single beam laser. Look, the machine we have, yeah, you can put that setting on. You remove the fractional side of things, and you can do operations with the laser as well. Most machines have that setting, so you can do that. Yeah,
With the same laser.
Yeah, it's got settings on it for that.
So you take off your grid diffuser and turn it into a wart ablator.
You can do warts if you want to. So, but I haven't used my machine for anything other than the vaginal laser. I mean, there are settings for the face and the all sorts of things on the actual machine I've got, but I haven't used it.
And then anonymous attendee, patients with low female intimate self-confidence, could it be considered a medical reason for vaginal laser therapy treatment, Steve?
No, absolutely. I mean, I think it's, it does improve patients' self confidence, it improves their sexual confidence. And I've got absolutely no hesitation in offering it to someone who feels that, this is something that could improve their vaginal tone, could improve their lubrication, remove some of their sort of atrophy effects. And maybe in your patient post-delivery, it's really not the type of patients I've been seeing for laser. I don't market it for that at all. But I mean, some of these other doctors use it extensively for vaginal tightening, and it does seem to work. So,
in premenopausal patients, so you can
yeah.
use it for vaginal tightening.
I think so.
Okay. All right.
And there was that one systematic review on it as well.
Well, Steve, we've had a wonderful afternoon talking about this. It's very illustrative of, oh, here we have another one. Gary Groenewald says, any evidence with respect to efficacy, radio frequency versus CO2 or YAG laser for atrophy?
It's a good question, Gary. I think it was a Thai or Korean doctor at Ayuga about 2 years ago who spoke about doing an RCT on that. And I have to admit, I haven't looked out for that data recently, but I'm pretty sure there will be an abstract by now, or maybe even a published article on that. But absolutely, greatest question of the night. I think, what do we do? Do we do radio frequency? Do we choose a machine with YAG or CO2? And I know Gary's also got quite a lot of experience with laser therapy. So I don't know. And I mean, that might actually dictate to us what machine, what therapy to actually acquire for your practice. So if you are interested in buying one of these machines, maybe do a little bit more research around those 3 specific questions that Gary's brought up here. Go for radio frequency, CO2, or YAG laser. That would probably be my advice to you.
Well, Steve, thank you so much. Sadly, we've got to the end of our bandwidth for this afternoon. And just to remind people that next week is, in fact, a public holiday. So there won't be a presentation next Thursday. And the following Thursday is, unfortunately, Easter, so there won't be a presentation that day either. But the next webinar, ladies and gentlemen, will be for the 4th of April. It's the beginning of April, and that's Clayton Hall. And he will be presenting a topic of data privacy and the POPI Act. This is a very topical thing, Steve. The rights and obligations of patient and healthcare practitioners protecting the freedom to privacy. So our medical legal forum is always very, very popular. And I'd like to then thank people that have been with us this afternoon. Over 200 people, Steve. And next time then, the 4th of April, is Clayton Hall once again with a medical legal presentation. So on behalf of all of us, I'd like to thank Steve. No, I'm thanking you, Steve, on behalf of all of us, that you've taken the time and trouble to prepare this talk. And a special thank you then for Karain, our technologist and technician, and she's going to be with us again on the 4th of April. So I've done the medical the MCQs, which stands for multiple choice questions. It has to be, in terms of the new Multiple Choice Question Act, a new format, and that I have done. You have to answer either A, B, or C. They said my questions are too easy, so these are much more insightful, and you can get 1 CPD point if you get your CPD correct. It has to be 40% pass rate. Steve, even you can pass that. So, ladies and gentlemen, thank you once again. A great pleasure having all of us now. It's now 6 o'clock, and we look forward to seeing you then in 3 weeks' time on the 4th of
3
April.
weeks, oh, okay, good. Enjoy the Easter weekend and other holidays. Thank you. Bye-bye.
And enjoy Ramadan, those of you that celebrate Ramadan, Steve.
And obviously Easter, if you celebrate Easter.
Yeah. Thank you very much.
Thank you very much. Thank you.
And good night.
Good night.